Hi everyone, and welcome back to the BIDMC EKG curriculum. I'm Janet Monroe, PGY3 at BI, and I'm joined by Dr. Michael Gavin today to discuss bundle branch blocks. Our learning objectives today are to review the normal path of the cardiac conduction system, understand the QRS morphology with bundle branch blocks, and identify left bundle branch blocks, right bundle branch blocks, as well as hemiblocks and bifascicular block. This is the sample EKG that you received earlier this month. If you haven't had a chance to look at it yet, please feel free to pause the video and take a few minutes to review it. We'll be going through this together later in the video. Let's talk about the conduction system of the heart under normal circumstances. In your right atrium, you have your SA and your AV node. Your SA node communicates with your AV node, and from there, electricity proceeds to the bundle of His, which then divides into the right and left bundle branches. The left bundle branch further breaks into the left posterior fascicle and the left anterior fascicle. It's important to remember that communication along these bundles occurs much more rapidly than myocyte to myocyte conduction, which explains many of the EKG findings you see in bundle branch blocks. Let's talk about bundle branch blocks. In the case of a right bundle branch block, as you see here, conduction proceeds quickly from the AV node down the left bundle and through the left posterior and anterior fascicle. From there, depolarization proceeds myocyte to myocyte towards the right. Similarly, with a left bundle branch block, as you can see here, conduction moves down the right bundle branch and then moves more slowly across the left towards the left ventricle with myocyte to myocyte conduction. You can also see isolated left posterior fascicle or left anterior fascicle blocks, as you can see here. There are many causes of bundle branch blocks, including acute inflammation, such as an acute MI or myocarditis, as well as fibrosis and infiltrative diseases. You often see bundle branch blocks with things like hypertensive cardiomyopathy, as well as with coronary artery disease or SCAR. Let's talk about the EKG findings for bundle branch blocks. We'll be using the precordial leads for most of this discussion, particularly V1 and V6, V1 being the most anterior lead and V6 the most lateral of the precordial leads.
So this is a demonstration of normal depolarization. You see that the electricity comes down from the SA node through the AV node, and the initial forces, the very initial forces, are towards the right ventricle. This is a septal activation. So really what you're seeing early on, heading towards V1, is the septal activation and away from V6. But then very rapidly towards the left ventricular musculature, which dominates the EKG, which is much more muscular than the right ventricle, we see your electrical movement away really from V1 and towards V6. So you get the positive deflection in V6 and the negative deflection in V1. So it's really septal activation and then left ventricular domination of the electrical forces with very little seen from the right ventricle here. So for left bundle, again, the electricity really initiated from the same spot from the SA node through the AV node, but you see that the block here, at least is high up in the right bundle. So all electricity is now going to travel down, high up the left bundle, excuse me. All the electricity is going to travel down to the right bundle here. And the septum then is activated from left, or rather from right to left. Now you may not see that. If there is a little bit of septal activation towards the right, you may get a little nub, a little R wave in V1, that's possible. If it's all really dominant towards the left ventricle, you're not going to see anything. So initial forces here again are septal, the septal forces here, septal forces here initially, and then it's really all the electricity making its way slowly into the left ventricle. So that's the difference here. That's why the QRS is so wide, is that you're activating myocyte to myocyte instead of down the native of the electrical system here. So your QRS then is widened, but still slow towards V6, left ventricular activation, and away from V1 in a left bundle branch block.
Right. And do you happen to know, this is actually just a point of curiosity for me as well, why you sometimes see that little notch in V6 there?
It probably, there's some break in the way the electricity travels. So probably these early forces still are, what we're seeing in this early portion here, and this is just exaggerated, I think, is this. And that's still happening down the right bundle. So you're activating the septum via the right bundle, which happens fast. And that's why when you look at, trying to determine VT versus not VT, this RS duration is relevant. So the RS duration, the longer that is, the more likely it is to be VT because you're now activating through muscle the whole time. So again, the drawing is a little exaggerated. In reality, those portions are sharp. And so this early part here is still activated down the native conduction system via the right bundle through the septum. And then you start to leak out really and activate the rest of the left ventricle through myocyte to myocyte communication. So that's probably, I think that's why you really see the bundle, the notching, excuse me. So right bundle, now we have the block here in the right bundle. So the left side of the septum activated first, which generates some leftward towards rightward septal activation, which is actually truly kind of posterior to anterior. So that's where we get the small septal activation here. And the septum's a good bit of muscle. So you'll see it. It's not the right ventricular free wall. And then later, let's see, you have initial septal activation, then left ventricular activation, still sharp, still in the early portion. So left ventricular activation down the left bundle, that's all of this here. So down the left bundle, that happens rapid. And then the leak myocyte to myocyte happens to the right ventricle. And so here in V1 is an RV lead. So that's why it's sitting right over the right ventricle. So even though there aren't a lot of myocytes in the right ventricle, you can pick it up electrically. It's not dominated by the LV here in V1. And so that gives you the R prime. And that's why the R prime is wider. So typically, you have your R, and then your R prime is wider because that's myocyte to myocyte communication. That's not down the native conduction system.
Let's talk more specifically about the EKG criteria for bundle branch blocks. For both left and right bundle branch blocks, the QRS duration will be greater than 120 milliseconds. For left bundles, you'll see a broad monomorphic R wave in leads 1 and V6 without any Q waves. You also have a broad monomorphic S wave in lead V1. As Dr. Gavin mentioned, and as you can see here in V1, you might also see a small R wave. For right bundles, the QRS again is greater than 120 milliseconds. You'll see a broad slurred S wave in leads 1 and V6, and an RS-R prime pattern in lead V1, which you may hear described as a bunny ears pattern. You can see that here as well. Now it's time for some practice. This EKG will look pretty familiar to you if you had a chance to look at the sample EKG earlier. If not, take a second to pause the video so that you can look at it yourself before Dr. Gavin goes through it with us.
A typical appearance of right bundle pattern. Let's go back to the standard pen. So there's our R prime, RS, R prime. Okay. So there's the R prime again, coming back towards the right ventricle in V1, away from it in V6. And similarly, then this is the movement instead of towards the left side. So lead 1 is towards the left side. This is moving actually away from it. So that's kind of reactivating, or not reactivating, it's activating the right side late because the right wing moving down through the left ventricular native conduction system and then back to the right. So that gives you your S there.
Here's another practice EKG. Again, feel free to pause so that you can take a look at it yourself before we go through it.
So now thinking about left bundle branch block, we see a small, sharp R wave here. And that small, sharp R wave is the forces coming from the right ventricle going towards the left ventricle down the septum. All right, so these are septal forces. Sharp septal forces down the right bundle, very fast, very narrow, activating the septum from the right side. And then everything thereafter gets dominated by the leak over to the left side. It's not really a leak, it's just that, again, it's down the right, everything's activated fast, and then everything slowly makes its way out to the left side. And that's why you get this wide QRS out in V6, which is looking towards the left. Similarly, again, I just talked about with lead one, looking towards the left, and that's what we're seeing there. But these very early forces going from here up and down are relatively sharp. So this early portion is sharp because it's all happening very fast down the right bundle, then everything goes to the left. So this looks different if you were to have ventricular origin of this. These early forces are also more slurred.
Next, we'll talk about fascicular block or hemiblock. You'll often see this abbreviated as LAFB or LPFB, indicating a left anterior or left posterior fascicular block. An isolated left posterior fascicular block is less common, since the fibers of the left posterior fascicle are much more broadly distributed than those of the left anterior fascicle. You can also see a bifascicular block, which is a right bundle branch block, as well as a left anterior or left posterior fascicle block. A left anterior fascicular block includes left axis deviation, with a positive QRS complex in lead 1 and a negative QRS in AVF. You'll see either a QR or an R wave in lead 1, as well as an RS complex in lead 3. Take a couple seconds to look at this EKG and see if you think it meets the criteria for a left anterior fascicular block.
So the first thing with left anterior hemiblock or left anterior fascicular block is the left axis. So you have to have a left axis, and that's largely where you're starting. The other thing you often see with a left anterior fascicular block is the late R wave progression, almost to the point of looking like an old anterior infarct. And really what's happening there is there's a counterclockwise activation to the left ventricle. So as you can imagine, kind of counterclockwise means the later activation out towards V6. There's often a delayed R wave progression, a left axis deviation, but you're still ultimately starting, you look at V1, you have a little QR and then typically an RS in lead 3. Those are the kind of classic examples of this. There are other things, though, that cause left axis deviation. Often that's left ventricular hypertrophy, so you're looking at VOLTs and AVL. And the VOLTs and AVL here are pretty close to meeting criteria for LVH, so you'll see on many EKGs a call of both left ventricular hypertrophy and left anterior hemiblock. And it can be difficult to distinguish those and their bedfellows because structural heart disease, hypertensive heart disease, and conduction system disease go hand in hand. And so you're often going to see these fascicular blocks in people with hypertensive heart disease. But so it'd be a little bit tricky to tease those out, but generally left axis deviation, delayed R wave progression, and the QS in 1, RS in 3.
A left posterior fascicular block has a rightward axis with a negative QRS complex in lead 1 and a positive QRS complex in leads 2 and AVF. You'll also see an S wave in lead 1 and a Q in lead 3. Importantly, you do need to exclude right atrial enlargement as well as RVH to make a diagnosis of a left posterior fascicular block. Take a couple seconds to look at this EKG and see if you think it meets those criteria.
Yeah, so you're looking at this and you're saying, okay, clearly there's right axis deviation. P wave, maybe some left atrial enlargement, hard to say. It's not, you're not looking at a P wave like this. All right, that would be more convincing of right atrial enlargement. You're not seeing a big R wave in V1 and V2 suggesting right atrial enlargement. You are seeing LVH though here, right? So there is an argument to be made now, right? Okay, so LVH shouldn't be shifted to the right. So you then generally would conclude that, okay, it doesn't look like biventricular hypertrophy. It probably is LVH with a right posterior fascicular block. That explains it. The other thing to be very careful about, though, when you see a right axis deviation, is make sure your P wave is not this. Because if you have inverted P waves, it's probably limb lead reversal. So when I read a basket of EKGs, I'm seeing more limb lead reversal than I am pure right axis deviation.
A bifascicular block, as mentioned previously, is a block that includes both a right bundle branch block as well as either a left interior fascicular block or a left posterior fascicular block. Take a look at this EKG and decide which one you think this is.
Yeah, so in this case, what we have is the right bundle. Okay, so you have a right bundle branch block and you have the left axis deviation here, negative in the inferior lead. So, and the QRS is a bit wide. You have the RS in one, you have the QR, or sorry, the R, little r and a bigger S here in lead 3. So right bundle, left axis deviation with a morphology consistent with left anterior hemiblock. So that's, I mean, it's a confusing term, bifascicular block. Really, it's a right bundle and a left anterior hemiblock. And so just suggests that really you're living now off the left posterior fascicle. One more thing goes down and you could have complete heart block. An indicator of more advanced conduction system disease. And then you occasionally hear the term trifascicular block, which is a total misnomer and refers to also having a prolonged PR interval. But the PR has nothing to do with the left posterior fascicle, just as either slowing in the AV node or in the His. So that is a term that can be confusing, probably to be avoided, and actually exists here because the PR interval here is not normal. That's prolonged.
Okay, now it's your turn. Pause the video and take a few minutes to go through this EKG. We'll go through it at the end of the video together as well.
Yeah, so in this case, right, I'm looking at it now. You tell me what the final read was, but right bundle morphology, you don't have quite the classic RSR prime, but right bundle morphology and axis is shifted to the right. So upright here in the inferior leads, but shifted rightwards in lead 1. And so in this case, you know, you see some other things. Are these septal Q waves, or is this indicative of a prior inferior wall infarct? So probably the, you know, I'm looking at, I'd say can't rule out an inferior wall infarct. It's wide enough. It's not quite a third, so that the ratio of this Q wave to the total QRS complex matters, as does the width, but it's wide enough. So maybe there's an inferior infarct here. But a right bundle branch block with a right axis deviation. So this could be right heart strain and right bundle branch block. Things like RV cardiomyopathies or an acute insult to the right ventricle. It could be right bundle branch block and left posterior fascicular block. An echo ultimately will help you distinguish between those. Right bundle branch blocks are more common than left bundle branch blocks in general, and we just see it in association with lots of different things. Now, people come in with a right bundle if they're young, and there's an RSR prime pattern of a juvenile EKG, but if that persists, then you have to start thinking about things like ARVC, or is this right bundle really Brugada, or right bundle RSR prime patterns persist and people have ASDs and some right ventricular enlargement. So in a young person with a right bundle, 25, 30 years old, those are the conditions that you're thinking about. Is there some RV pathology or ASD here? As people get older and middle age and beyond, to see an isolated right bundle and hypertension is extremely common and doesn't warrant a lot of investigation. In fact, it doesn't even warrant an echo. An isolated left bundle in a young person, or in somebody who's older, just has nothing else, you might get an echo. Most of the time, it's going to be completely normal. Every once in a while, you're going to pick up a cardiomyopathy. Left bundles can be left and right, you know, really can be associated both with infiltrative cardiomyopathies, dilated cardiomyopathies. In the acute setting, something like myocarditis that's affecting the conduction system, a prior infarct that they didn't know about. So some judgment needs to be made as to when to order an echo, but an isolated right bundle with hypertension, no. Isolated left bundle with hypertension, probably still no. But an isolated abnormality with nothing is totally normal host. No risk factors. I think at least it's worth a one-time investigation, because those are the things that are running through your head. But in the hospital setting, the idea of CAD or an infarction causing a bundle, they don't look like the bundles you're used to. So when you melt the conduction system via large anterior wall infarct, there's some ST segment elevation typically hidden in there. It's usually a right bundle, left anterior fascicular block, but you have elevation here instead of the standard depression. They're a little uglier looking. So a left bundle is not a STEMI equivalent. It just means you can't interpret what's going on underneath it. Again, when you have a large anterior wall MI, it's typically right bundle, left anterior fascicular block with this elevation here. So that's the left bundle, somebody come in with chest pain. All you can say there is they might be having ischemia here. I just can't tell. The EKG doesn't help me. So I got to go to something else, namely an echo or an angiogram.
Okay, that concludes our lecture for today. Thanks so much for tuning in for this lecture on bundle branch blocks as part of the EKG curriculum, and we'll see you next month for the next installment.